First of all, grateful thanks for the opportunity to speak. Grateful thanks to the organizers for the invitation and participation, and greetings to all who are listening in, and thank you for your attention and for your time. So the topic given to me is Philadelphia Conundrum and the role of TKIs in childhood cancers, and I shall focus very narrowly on the question of in the context of acute leukemias. And the title itself is a bit of a conundrum. So a conundrum is a puzzling question, and what I have done is I have taken the liberty of splitting it into two questions. First is Philadelphia in the context of Philadelphia-like acute leukemia, because I think there is less ambiguity about Philadelphia positive ALL. And then once identifying, recognizing it, how do we then treat it using tyrosine kinase inhibitors? So if we take conundrum one, and then the first question is how do we recognize it? And recognizing and not just identifying it, but then placing it in the clinical context. So there are, again, four questions confronting us. What is it? How common is it? How do we diagnose it? And what are the outcomes reported in this particular disease context? And, as this has been mentioned by speakers before me, so using cytogenetic approaches, which is a combination of karyotyping and fluorescence in situ hybridization, complemented by DNA flow ploidy, we identify at least four major subgroups of cytogenetic alterations in acute lymphoblastic leukemia, which are highlighted above in the panel. And those which do not fit any recurrent cytogenetic abnormality are then categorized as the B other cytogenetic group. So the Philadelphia-like ALL actually comes then into the subtype of the B other cytogenetic group. And as defined earlier, it is a subtype which has a gene expression signature matching that of BCR-ABL1 ALL, but without the genomic alteration. And it has been variously reported as characterizing a poor risk subgroup, and where there is an opportunity for treating it with a tyrosine kinase inhibitor together with multi-agent chemotherapy. Now, when we look at how common is it, I mean, why are we talking about it? So let's just take it into context. So again, let's go through the flow. Patients with newly diagnosed leukemia, children. Let's say we have 200 children. We have identified a B other cytogenetic subtype by excluding the other recurrent cytogenetic abnormalities. Now then we are confronted with this question, is this PH-like ALL? And gene expression signature analysis is fraught with difficulty from a laboratory diagnostic point of view. So we look at more stable markers, which are gene alterations, which define kinase pathway activation. And when we do that, as I indicated earlier, we're left with three major classes. The first class is the ABL class kinases, which are rearrangements of genes in the ABL kinase pathway. And these are targetable by the ABL class tyrosine kinase inhibitors, which you recognize as imatinib, dasatinib, nilotinib, and the other molecules in that family. Then we have the JAK-STAT signaling pathway, looking at either the cytokine receptor-like factor 2, which is on the surface of the cell, or its downstream molecules, which are in the pathway, and then rarer kinases, which I shall not dwell upon. But when we then look at the numbers and break it down, so these are the reported numbers. Now, please remember, these are derived from Western literature, and there may be some ethnicity-specific alterations. So we do not really know how relevant is this in our populations, but nevertheless. So about a third of patients have B other cytogenetic subtype. Half of them have the PH-like ALL. But if you look at the ABL class kinases, which are the ones of real clinical interest, they're probably about 10%. So overall in 200 patients, we're probably going to see about 3. The CRLF2, even though they are talked about much, actually at the moment, we do not have any therapeutic strategy for them. The rarer kinases are very few. And if we break, again, down the JAK-STAT signaling part, we're left with these numbers. So these are the numbers we're dealing with. And you may then wonder what's the relevance of this talk, and we'll come to that at the conclusion of the slide. So then how do we diagnose Philadelphia-like ALL? So we go use a stepwise approach. First, we exclude the other recurrent abnormalities. I won't dwell into that. And then we then start asking the question, is this Philadelphia-like ALL? And we have two approaches. We can either use a preemptive approach where we screen all B other genetic subtypes for this particular category, or we have a reactive or more directed approach where we actually investigate it in patients with high risk features as outlined in the panel below. And there are merits and demerits of each approach, which I shall not dwell on. But when we then take and see, okay, what is the next diagnostic approach once we think we want to hunt for PH-like ALL, we are left with a conundrum here, because gene expression signature is what is used in the original description and now in the clinical trials, but these are very difficult. They are costly, they are labile, and they are not reproducible. For that reason, I think stable genomic alterations, even though they may miss a subtype, are probably more easy and more tractable. So we have genomic alterations which define kinase activation either by fusions or result in deregulation of the cytokine receptor signaling. And basically, there are two categories here: the able class fusions, which can be detected by extended FISH studies or targeted RNA sequencing. I'll come to that in a moment. Or CRLF2 expression, which can be recognized as previously indicated by flow cytometry studies and follow-on FISH studies. And I'll come to this in a moment in the next slide. So I'm going to draw your attention. I hope my cursor is visible. So this is so please look at the left side of the screen. And what you can see is the BCR-able at the leftmost side is an interface FISH image. And you can see the DAPI-stained nucleus containing the signals defining the BCR and the able loci. And what is evident signals which are defined by red. And that is a trigger saying that something is going on at the able1 locus. And when we put a break apart able probe, the fusion defines the normal abnormality. And what you can see here is that the able is split, suggesting that there is a rearrangement at the locus. And this can then, if you now turn your attention to the rightward panel, which is a karyogram, what is evident is that there is a structural abnormality representing fusion between genes at this particular loci. So this is both cytogenetically determined both by FISH and by karyotype, but FISH is the earlier, easier, the quicker way of picking it up, and the karyotype later. Now, CRLF2, it can be picked up by flow cytometry. I won't go into this too much, but I just wanted to qualify. I just want to qualify what was mentioned earlier, that just diagnosing CRLF2 alone is not sufficient. CRLF2 accompanied by genomic alterations which deregulate its activity, either because of translocations involving IgH or intragene deletions which bring together the P2RY8 promoter with CRLF2. Now, this doesn't form a chimeric fusion transcript, but results in deregulated CRLF2 activity. And now that is it. I'm making here is that the CRLF2 overexpression in of itself does not mean, refer to a pH like ALL. It has to be accompanied by genomic alterations, which results in CRLF2 deregulation, either by rearrangement with bringing the CRLF2 next to the IgH promoter, or intragene deletions within the CRLF2 locus, bringing it next to the P2RY8 promoter. So that point is important. Now, I want to now go on to the outcomes. So again, I'm trying to emphasize the point that my bias is focusing on the able class fusion of PH-KLL because the CRF2 overexpressed type of entity is a mixed bag, which may contain some pH-like ALL and some not really. So able class fusion outcomes have been reported in a wonderful paper, retrospective analysis by this group from the Ponte di Legno consortium, looking at European, North American, and Asia Pacific groups. And this is a wonderful paper, both for its quality and clarity. And what you can see here is that 122 patients, retrospective analysis, looking at non-TKI-based high-risk chemotherapy. These are the fusions reported in this particular paper. About 50% of them were PDGFR beta fusions, about a third of them with able class fusions. And look on the right because of older age, poor pressing counts, or poor response, high risk, and majority of them required high-risk therapy. So you can see they have high-risk features. And what you can see here is that if I draw your attention to the headlines, what you can see is these patients had poor risk features, high MRD, high event rates, inferior outcomes, and even with HSCT, even though the relapses were minimized, there were high treatment-related events. So therefore, this entity, the able class fusion, able class fusion ALL, which is a subtype of pH-like ALL, are entities with poor outcomes, which may benefit from tyrosine kinase inhibitor therapy. So that's the point I want to make in this particular slide. So then the question is, how do we then introduce tyrosine kinase inhibitors in this group? I just want to make a point here that the JAK-STAT activated pathway pH-like ALL, where intuitively they may be amenable to ruxolitinib therapy. Actually, preclinically there is activity, but anecdotally the effect is inconsistent. And therefore, it is what we are going to talk about now is more on the able class group, where there is probably a real opportunity to introduce able class directed tyrosine kinase inhibitors. I just want to show this particular schematic Just draw your attention to the fact that the COG group has now clinical trials looking at use of tyrosine kinase inhibitors in pH-like ALL and pH-positive ALL. This is defined by using low-density arrays to identify pH-like ALL. Please remember that this is difficult to reproduce in the diagnostic context. CRLF2 positive patients with accompanying genomic alterations are given ruxolitinib. Those without CRLF2 expression but have other downstream abnormalities of the JAK-STATs pathways are also given ruxolitinib. The safety of this approach has been demonstrated. The efficacy trials are still going on. Now, if I come to the TKIs in pH-positive ALL, to present this, I'm drawing on work done over past 2 decades from many groups, Europe. I'm just drawing the slide so that I want to try to draw this. These are the slides which are going to on which I'm going to base my next 2 recommendations. So, and more recently from the Chinese Children's Cancer Group, and I'm interested to see what Dr. Lee, Professor Lee is going to say in the next talk. So essentially for TKI treatment, both in pH-positive ALL and in able class pH-like ALL, I think it will be introduced as part of multi-drug chemotherapy. It has to be introduced probably in mid-induction when patients are clinically fit. The imatinib will be our first choice at this particular dose, and continuous dosing is a challenge because of GI intolerance in patients, which is a real deterrent to continuous dosing. When we do this, we see that the early response in terms of morphological remission and MRD clearance is quite impressive compared to historical non-TKI based interventions. This is in the context of pH-positive ALL. We think it will be reproduced in able class fusion ALL as well. But what I want to point out is that TKI plus intensive chemotherapy, the outcomes are probably about double that if you don't use a TKI. So TKI with the outcomes are about probably 60 to 65%. If you don't do HSCT, which is probably about 80 to 85%, these are MRD negative patients. The deaths are fewer, relapses are higher. If HSCT is introduced, deaths are higher, relapses are fewer. So overall, it evens out. These are some of the uncertainties of which is the right approach. Is it dasatinib or imatinib, chemotherapy, which backbone? All these are some of the continuing questions, whether we should transplant in first remission, etc. I think this is my last slide, and I'll skip the, so even though it's such a rare entity, I think this entity forces us to work collaboratively, and advances in diagnostics, opportunity to introduce new agents, and also do biological studies. And I just want to draw attention to this quite impressive work published by colleagues from Tata Memorial Hospital, Mumbai, using a target RNA sequencing approach to identify quick turnaround, cheap cost. I think I've finished. I just want to say that beyond pH-like ALL, we also have kinase activated ALLs, which are probably also seen in other cytogenetic categories. So suggesting that kinase activated phenomenon may not necessarily be restricted to the pH-like context. Thank you.